Immunology Insights, Basics and Beyond. Chapter 37, Graft Rejection, Mechanism and Prevention. Marcello here. Welcome back to Immunology Insights, Basics and Beyond. In our last episode, we pushed the boundaries of treatment strategies for autoimmunity by learning about the latest cutting-edge therapy approaches. This sets the stage for today's topic: how that same immune vigilance can become both friend and foe in organ transplantation. This is the first of 5 chapters on transplantation immunology, and we start with the central challenge: graft rejection. So let's talk science. What actually causes graft rejection? Graft rejection happens because the recipient's immune system recognizes the transplanted tissue as foreign, primarily due to differences in major histocompatibility complex or MHC molecules, especially MHC class I on the donor's cells. These molecules normally present peptides to the immune system to indicate whether a cell is healthy or infected. However, because the graft expresses the donor's MHC, the recipient's immune cells see them as non-self. This triggers a strong immune defense similar to the response against infected or malignant cells. This immune attack can be rapid and violent or slow and smoldering, but the underlying issues are the same. The immune system was built to detect and eliminate anything unfamiliar, and the donor organ fits that bill unless steps are taken to suppress or redirect that response. What is graft rejection? Well, graft rejection is the process by which the immune system of a transplant recipient attacks and damages the transplanted tissue or organ. This immune response can involve T cells, antibodies, macrophages, and complement proteins, all working in concert to destroy what is perceived as a dangerous invader. Rejection results in cellular damage, vascular injury, and ultimately loss of graft function. If not prevented or treated, it leads to partial or complete failure of the transplanted organ. There are different types of rejection. First, hyperacute rejection, which only takes minutes to hours. This occurs almost immediately after transplantation if the recipient already has antibodies against the donor's ABO blood group antigens or MHC molecules. These pre-existing antibodies trigger complement activation and clot formation, leading to immediate thrombosis, ischemia, and necrosis of the graft. For instance, a mismatched kidney may not even begin functioning. It stays pale and flaccid on the operating table and never pinks up, meaning it fails to become perfused with blood. Second, we have the acute rejection, which takes days to weeks. This is primarily a T-cell mediated response where the recipient's cytotoxic T lymphocytes recognize the donor's MHC on graft cells and begin attacking them. The result is inflammation, cellular destruction, and impaired graft function. Acute rejection is the most common cause of early graft failure and can often be reversed with prompt immunosuppressive therapy. Third, we have the chronic rejection, which takes months to years. A slower and more insidious process, chronic rejection involves long-term immune responses that lead to vascular damage, fibrosis, and scarring of the graft tissue. It manifests as chronic allograft vasculopathy in heart transplants or transplant glomerulopathy in kidney transplants. Unlike acute rejection, it is often irreversible and leads to gradual graft failure despite immunosuppression. What are the immunologic mechanisms behind that? First, we have the direct allorecognition. The recipient's T cells directly interact with the donor antigen-presenting cells, so the APCs, carrying foreign MHC molecules. This activates cytotoxic T cells, which then infiltrate the graft and destroy its cells. Second, we have the indirect allorecognition. In this more delayed pathway, recipients' APCs take up donor antigens, process them, and present them to helper T cells. This promotes the production of cytokines and the recruitment of B cells, leading to antibody formation and chronic rejection. Third, we have the humoral, so antibody-mediated rejection. Here, B cells produce donor-specific antibodies or DSAs that bind to antigens on the graft's vascular endothelium. This activates the classical complement pathway, leading to inflammation, endothelial damage, and potentially graft thrombosis or dysfunction. What are clinical clues for graft rejection and how does the diagnosis work? Well, clinicians monitor the signs of rejection using a combination of lab values, imaging, and histological findings. First, of course, organ dysfunction. Elevated creatinine in the kidney, liver enzymes, or troponin in the heart can be early clues. Second, biopsy findings. Infiltration of the graft by mononuclear cells, endothelial swelling, and the presence of C4d deposits are hallmarks of antibody-mediated rejection. Third, detection of donor-specific antibodies. Laboratory tests like Luminex bead assays and flow cytometry crossmatch can identify circulating DSAs that correlate with higher risk of rejection. What are prevention strategies? First, we have the donor-recipient matching. Matching human leukocyte antigens, HLAs, and ABO blood types reduces the likelihood of immune recognition and rejection. Second, we have cross-match testing, which ensures that the recipient does not have preformed antibodies against the donor, avoiding hyperacute rejection. Third, desensitization protocols. In highly sensitized patients, plasmapheresis, so removing antibodies from the blood, and intravenous immunoglobulin, IVIG, can reduce harmful antibody levels before transplant. And fourth, immunosuppressive regimens, which typically include a triple drug protocol, a calcineurin inhibitor like tacrolimus, an antiproliferative agent like mycophenolate mofetil, and corticosteroids. These suppress T cell activation and proliferation while reducing inflammation. What are future directions of the treatment of graft rejection? As first example, we have new organ perfusion system. New perfusion techniques allow grafts to be maintained and cleaned outside the body before transplantation. This may help reduce the number of active donor APCs, lowering the risk of acute rejection. As a second example, we have xenotransplantation and gene editing. For example, pigs are being genetically modified to remove antigens like alpha-gal, which commonly trigger rejection in humans. Although still experimental, such advances may one day expand the donor pool and reduce the need for harsh immunosuppression. To conclude, graft rejection illustrates both the elegance and the ruthlessness of the immune system, always on guard even when a new organ is meant to save a life. Understanding the mechanisms behind rejection is not just academic. It is the foundation for life-saving transplant medicine. Every successful transplant depends on the delicate balance of immune tolerance and suppression. Organ transplantation offers a chance at life for patients with end-stage organ failure, be it kidneys, livers, hearts, or lungs. But it's not without risks. Infection, malignancy, medication side effects, and long-term rejection remain real challenges. That's why the science of immunology, pharmacology, and biotechnology continue to play a crucial role in advancing this field. In our next chapter, we will explore the pharmacologic tools we use to control the immune response, from broad-spectrum immunosuppressants to the newer, more targeted agents that aim for efficacy without excessive side effects. Before closing, I have a small request. If you enjoyed my content and want to hear more, like and subscribe. It's a small step for you, but it helps me a lot. So, see you next time and thank you for listening.